I do want to welcome Jez, Lisa, and David from Elevate Patient Financial Solutions. Today, they're going to be reviewing general requirements and best practice solutions for out-of-state Medicaid enrollment in Kansas and in the neighboring states. So with that, I'm going to turn it over to David to get us started today.
Very nice to be here, and thank you for spending an hour with us. Jez, would you pop it to the next slide? My name is David Cartier. I'm our Vice President of Business Development. I've been in healthcare revenue cycle for just over 30 years now. I wanted to introduce Jez Garcia. She's our Regional Vice President for out-of-state. So OOS, if you see OOS, that's out-of-state operations. And then also Lisa Almaraz. She's our Executive Vice President for Strategy. We're all really happy to be here, and we'll be spending about 30 or so minutes going through our presentation, and then we'll have plenty of time. Well, we'll make sure we have plenty of time at the end for questions, but please, if you have questions along the way, throw them in the chat and we'll get them answered. I want to make sure we get all the answers that you need. All right, next slide. And we're going to do an overview, do a quick, very, very quick overview of Elevate. Then we'll go into what is out-of-state Medicaid and what are the big challenges. We'll step into, go through all the steps needed for provider enrollment. We won't spend any time with patient enrollment, but if you want more information on that, I'm happy to share. And then, provider enrollment and billing. We'll go through all of your surrounding states and call out all of the difficult ones and get you some information there. And then some tips on how to manage the process. A little bit about Elevate. We've been around for about 40 years. We have an amazing set of leadership. I think just Jez, Lisa, and I probably are close to about 80 years experience of the 300. So I think that's a low number. We have about 2,700 employees across the country. We have many, many, many clients, 1,700 client sites, and we are really, really proud of our client retention rate. We work and work with HFMA a lot. We have a Great Place to Work certified and one of the top performers in class. All right, next slide. Just a quick overview. When I mentioned eligibility and enrollment, that's working with self-pay patients, getting them on, including out-of-state patients. We work under complex claims with out-of-state, what we're going to be talking about today. Also, third-party liability, workers' comp, veterans, and COB denials. Our AR services, full suite of billing follow-up, and then also self-pay early out. All of our services are kind of built around working with patients, finding ways to help manage the process, and turning over every stone to help streamline the process for both patients and our partners. All right, next slide. I'm going to turn this over to Jez, our out-of-state Medicaid billing and enrollment program. Jez's team manages about 60,000 claims, out-of-state Medicaid claims per year, and in that also about 3,000 plus provider enrollments. And we work with every state across the country and all of the different payers on a daily basis. All right, I'm going to turn it over to Lisa, and then yes, she'll send it to Jez.
Thank you, Dave. Well, as many of you guys know, each state's Medicaid plan comes with its unique set of rules, the deadlines, and policies. With more than about 450 different Medicaid payer profiles, navigating through those nuances just without the help of experts can certainly be tricky. And sadly, many of the out-of-state claims end up falling through the cracks. So this often really results in providers having to write off these services, which is obviously far from ideal. The unique enrollment requirements and the constant changes leave providers really feeling extremely frustrated with the process, as many of you guys have experienced yourself. And that frustration level is understandable given the complexity and the frequent updates that seem to keep everybody certainly on their toes. But the great news is that it really doesn't have to be that way. With the right strategy and support, you guys can certainly successfully navigate these complexities and alleviate some of the stress and confusion that it's causing while just ensuring that you guys receive all the money that's due to you. And it's really all about having a well thought out process and approach and the right expertise on your side. If moving on to the next slide, I'll talk through just a little bit. I wanted to take a moment to discuss the importance of a proactive AR management strategy and how it can really help you alleviate the financial burden often seen with the out-of-state payers. It's crucial really to know the filing deadlines for each state and implement a streamlined tracking mechanism to effectively monitor and escalate accounts nearing these deadlines. This can really help avoid any of those technical denials that we typically see that could otherwise impact the financial health. Additionally, reconciling the inventory to capture all associated charges and claims really kind of help you enable to keep you a close eye on not just the cumulative charges, but also those particularly high dollar accounts and aged inventory as well. And one of the strategies that we've utilized that's really has helped us monitor performance is really keeping a close eye and monitoring those monthly volumes, not just by state, but also by payer. What this approach does is it helps you analyze that historical performance and quickly identify any sort of opportunities that might exist for improvement, and most importantly, tracking some of those denials by payer a little bit more closely. Many organizations evaluate also the viability of inventory and making those necessary business decisions on accounts with a low likelihood of inventory. Implementing similar measures will also help you make informed decisions and optimize the AR management strategy. And then the last key component that I'll talk through is just reporting and being able to monitor and have the reports to monitor those recovery rates by state and overall progression of accounts really can help track some of those delays and trends that can really help provide a revenue lift on out-of-state AR. And then just to creating the right foundation and approach, you can establish the necessary tools to really help improve the out-of-state AR overall. So I'm going to pass it over to Jez, and she'll dig into the details further in terms of the operational workflow and processes.
All right. Thank you, Lisa. Good afternoon, everyone. I'm excited to talk to you about the out-of-state Medicaid world. Just a little bit of background on myself. I actually was part of the hospital system for many, many years. And I was also doing the out-of-state Medicaid billing from the hospital side. So I'm excited because I get to continue to work on the out-of-state portion in my current position and just continue to really have a lot of great practices that we have had along the way. So the best thing, as Lisa has mentioned, we really need to have a really good workflow, right? You need to know exactly what are these accounts. The majority of the time, you're going to have an out-of-state patient that's coming in that sometimes they think they have Medicaid, sometimes they don't know if they have Medicaid, right? So I think the number one thing is going to be that's really, really key is to first identify, are they really truly eligible for the data service? What are the actual benefits? Because might be that they're only eligible for certain benefits. And is that payer really truly out-of-state Medicaid? There are some commercial plans that are those types of things that you can see as well too. So really the key is identifying what it is that they are eligible for and who their HMO is. That is step number one. Once you have identified that, then from my perspective is you really truly need to understand who those payers are, especially for your surrounding states. What are the timely deadlines for the enrollment side? For the claim, do you need to start an authorization? Do you need to be enrolled in order for you to be able to start the authorization, right? So being able to really truly identify those particular states are key. So one of the things that Dave talked about is the portion of maybe the eligibility team being able to also get folks enrolled with out-of-state or with in-state if that's what they need. The purposes of today's presentation is going to be specifically on people that really truly are eligible for out-of-state for the data service. So once you have your payer identified, right, what exactly are those particular requirements for that state? So there are some states that are going to require itemized statements. As I mentioned, there are some states that are going to require the authorization to be completed or the enrollment itself. There's also several HMOs out there. So that's where it's really important to understand because the HMO may not require all of those things. So again, identifying exactly who the payer is and what those requirements are. Majority of your accounts that are inpatients or anybody that comes in through emergency observations and inpatients are going to require some form of authorization. Keeping the folks that are doing your authorization in the loop is making sure that they understand that there's an inpatient account, that they are out of state so that they can start that authorization right away. The majority of the payers will allow you to start the authorization without being enrolled. You do have some payers out there that will not allow you to start that authorization unless you are enrolled, but they'll allow you to retro back once you are enrolled. The next and the funnest part of it is going to be the enrollment verification. So the states require two types of enrollments, either the MPI that you have that's listed on your claim, so on your UB. For the facility side, all of the state plans, not HMOs, but the state plans require some form of enrollment. So whoever you have listed on your UB is going to be who you have to enroll for that particular state. Unfortunately, on the 1500 side or on the professional side, it's going to be dependent on how it is that you have your claims billed. The majority of the time, you are going to have your claims billed through a group, but then there are also times that maybe you're doing it through the facility side. So with those, unfortunately, you're going to have potentially two separate enrollments. You have your UB, whoever you have listed on your MPI, and then also on your 1500, whoever you have as the billing provider may also need to be enrolled if that state requires that. So once you have identified if enrollment is required, my recommendation would be is to start that enrollment if you're really truly not enrolled, right? And we'll talk a little bit more about what enrollment means and what the tracking can be and all of that kind of stuff. But I think it's being able to separate the enrollment deadline, the authorizations deadline, and then also your claims timely deadline. So those are the key pieces that you've got to make sure that you do. In a perfect world, we're already enrolled. We are good to go. We've got our authorization. The second piece that's really key and it's very important is that the majority of the payers now only allow you to bill electronically. So setting up those EDIs directly with the payers for those particular payers need to be done. Really, truly, I would say about maybe 10% of the payers allow paper today. The majority of them are going to be that you have to do that electronic billing in one way or another. So again, managing those particular payers, looking at your entire inventory, who is coming to your facilities? Are you a type of facility that people are coming in for maybe during the summer or those types of things? Or are you a type of a facility where you are going to be doing some specialty surgeries or specialty services that really truly require you to ensure that your providers, that your facility is enrolled with those particular states? So key, again, is to ensure that you have those electronic payers set up within your system, having a good process in place for that, looking at your rejections. But you've got to make sure, unfortunately, is that you've got to make sure that you are keeping up with your enrollment deadlines and also with your claim deadlines. They're not necessarily the same deadlines. You have separate deadlines. Most of them are the same. You have some payers that are, when it comes to the enrollment, they only allow you 45 days. So Illinois allows you 45 days from the admin date, not discharge, but from the admin date for you to be able to complete your enrollment. The claims process is different, but at least from your enrollment standpoint, 45 days is the shortest that we have so far. And then you have some payers that allow you all the way up to 1 year to be able to complete that enrollment. Once everything is perfect, you get all of your payments in place, everything is posted, you go ahead and get those returns accounts. Again, reconciliation, making sure that you've done your contractual adjustments, your charity. Some organizations may potentially still do charity if maybe the patient is eligible for the data, is not eligible for the data service, but they are eligible for Medicaid today. So a lot of, depending on who your charity or your compliance deadlines are, or your compliance situations are, you may want to look into that, right? Because if it is something where there is no propensity to pay and you're really truly trying to collect from someone that is eligible for Medicaid today, but just not on the data service, right, being able to manage that AR in that sense as well too. Now I'm going to go ahead and go to the next slide that we have, which is the enrollment piece of it. So from my perspective, being able to have a really good understanding of what the enrollments are and what the requirements are by state is key. So being able to identify some way to have those particular payers and updating the information, because the payers are continuing to make changes. So they have quite a bit of information that they're updating throughout the times. They may be updating portals, they may be updating different things. So it's just making sure that you're staying in the know of what's going on, especially for those particular payers that the majority of your clients or patients are coming from. So the biggest key that we have is, again, what exactly is needed for that particular payer, and how are you able to have your representatives or your specialists identify that really truly an enrollment needs to be started right away. That is one of the things that we have is we want to make sure that we have who is the particular facility, MPI, right? Who are the providers that are listed? When it comes to enrollment, if that particular state requires the facility and the physicians to be enrolled, that means that it needs to be all of the physicians that are listed on that claim. So if you have 5, 6 different physicians listed on that claim, especially for some really high dollar accounts, all of those physicians that are listed on the claim do need to be enrolled. So it's not just one physician, it's everyone that you have listed on that claim. So the other thing too that is important is going to be is when are those particular enrollments going to expire? There are some payers out there that will allow you to be able to just send in a simple form that says, yes, I want to continue to be able to be enrolled with your state. Also, there are some states that will only allow you to start an enrollment when you have a claim. So those are things that you need to be cautious about as well too. But more importantly, for your states where you have the majority of your traffic is really truly knowing when are you enrolled, when are you going to expire for that particular MPI, and then just again, make sure that you're maintaining everything as far as like knowing where to go for your updated licenses, CLIAs, those types of things. That truly is the key. And how do you then identify a way to be able to give that information to the people that are doing the day-to-day work on those accounts? If something is missed, can somebody catch it right away to ensure that there is an enrollment that is required? Let's get it to the right place so that we don't miss any of those deadlines. All right, so here is the actual enrollment tracking, right? So again, it's identifying when you're making the decision that you want to be able to participate in a particular state. So this information will be shared in the presentation, just as far as what we would require in order for us to be able to start that enrollment, right? So again, making sure that you have the right people in place. Who is your credentialing people that's doing your Medicare enrollments? They're going to have all this information, right? So W-9s, your CLIAs, DEAs, you got to ensure that you have everything that is listed on each application. What we have done and we continue to provide for our staff is making sure that there is an updated process of anything that's required. So if there's a state that's made a change where now they're requiring certain items, we'll update that tracker so that we can start that process and requesting that information right away. The other key thing when it comes to enrollment is you've got to make sure that your PACOS registration, so when you have your Medicare enrollment, that your board of directors are up to date, right? Are they really truly still there? Are they really truly still managing that process? Because it comes to the enrollment side of it, there are different payers that may validate the information that you have listed on your application from your PACOS enrollment. So if it turns out that your information is different, then at that point they may deny it and then require some additional information. There's a particular state where if that's not exact, then they will require the board of directors information along with their fingerprints and background check in order for you to be able to then move forward with that particular enrollment. So it comes to the facility side. The other question that I get a lot is, do you really truly need all of the board of directors information? And I wish I had a magic answer to that. And the answer is you absolutely do. So if they're listed on, again, your PACOS form, when it comes to the way that you registered for Medicare, if there is 10 people on as board of directors, if there's 3 or 4 as board of directors, then all of them would need to be listed on your Medicaid application as well too. So the biggest key to success here is going to be because as you can see, there's a lot of personal information that's going to be required in order for you to be able to complete this. So one is you've got to make sure that you have a good support system when it comes to the financial aspect of it, right? So how much of the amounts that you have, maybe there's one claim that's $50,000 that may have paid at a 20 or 30% reimbursement rate. But if you have one of those claims times, once a month, it may add up, right? So I think that the biggest thing is that just looking at how much of a loss it really truly is. Are you writing these off to a charity? Are these being, again, sent to bad debt, whatever the case may be, right? So in that situation is looking to see what is the true loss and what is it where you can actually take the information and be able to potentially get some revenue for this. But it's got to be with making sure that everybody is on board, that they're going to provide this information, and then having a secure way to be able to have all this information, right? The board of directors information, it's very personal, right? You're talking about their date of birth, their potentially the last four of their social security number. Texas in particular is also asking for the driver's license number. The same with California, home address, right? So it is a lot of personal information. So how do you keep all this information secure and only for the people that really truly need to have this information? All right. The next piece that I have is going to be on the physicians. So again, with the claims that comes from an out-of-state payer, the physicians need to be, if you have them listed on the claim, they have to be enrolled. So again, this information is going to be provided to everyone. This is just an updated list and we continue to go through and review it. New York is looking at potentially making a change to including the provider information. From my perspective is we got to make sure that we're staying up to date and making sure that there is a good process and if it's going to affect you in any way, shape, or form. New Mexico just recently changed their portal and they were down for, originally it was going to be 60 days. And then it ended up being a little bit longer. So how is that going to impact your revenue if you are not enrolled with New Mexico and you have a large claim that's listed there? So those are all things to look for. So keeping up with this particular process. Now, in this case, all states, it's a lot, right? But at least being able to have a good hold on your surrounding states, I feel like that's at least where you can be successful. The majority of your patients are going to come from the surrounding states. You'd be surprised, though, I do have some facilities in New York, and then I have patients that are coming from California or from Alaska or wherever the case may be. It just really, truly depends. So in this case, again, for the physician portion of it, you've got to make sure that you have the understanding of the requirements and then also making sure that you have a good contact of who are you going to go with to be able to get that information so that you can start that application. So one of the things that we have looked into that's a little bit different is I think that the majority of the time, physicians are a little bit hesitant about being part of a provider's list for Medicaid, especially for an out-of-state program. If, for example, they are a specialty doctor and they want to make sure that they stay within a certain program, right? They don't want to be part of this particular Medicaid or out-of-state. So one of the things that we do is we are actually doing the OPR application for the enrollment. And what that is that it's for the ordering, prescribing, and referring physicians that are listed on the claim. And it's a shortened version of the actual individual application. And what it does is it actually makes it so that these are just for services that have been rendered. You're able to get those claims paid. It's a much easier application. And I feel like that in this case, when we were able to get these applications in front of the physicians, it's a much easier conversation to be able to talk to them about it. Maybe have some sort of a letter, right, from either your legal department or someone that can really truly make them see the importance of being able to be enrolled for this particular service, especially if it's, I've seen certain accounts that have gone up to $8 million for an out-of-state claim. So we actually have $1 million all the claims all the time. They really truly add up. So it's just making sure that you have that information. All right. So the next slide I'm going to do is I'm just going to go through and these are the border states that we have. And so just wanting to go through and showing you a little bit of information as far as what is needed, right? So for example, for Kansas, I've mentioned on the board of directors information, the date of birth and the social is going to be required on the application. You also, whoever you have designated on your PAYCOS form for the signer, that's who's going to sign the applications. If that's not up to date, you've got to make sure that that's up to date as well too. As far as the documents that are required, we have the bank letter, the claim, the CLIA, DEA, hospital license, right? The tax ID letter, Medicare letter, W-9. So Kansas, as I mentioned, is one of the states that does require you to have a claim. You can't be proactive when it comes to that. So it is one that from an out-of-state perspective, you do need to wait until you have a claim in order for you to be able to start that application process.
Yes, can I interrupt? I had a question with OPR. Do all states allow
Yes.
that, and
Yes.
do some require full network contracting?
No. They all allow it. So as of today, all allow it. We do it for all of the states that require the physician to be enrolled. And so it is, again, a much easier application, and you're not enrolling them in any type of individual plan. It really, truly is the purpose to get that claim paid.
Yep. All right. Thank you.
You're welcome. So Kansas is one that also requires, so as I mentioned to you, you've really got to be able to understand what are the specific requirements, right? So Kansas, you have some HMOs that don't require the physician to be enrolled, but then you have the state plan and then different HMOs that will require you to have the physician to be enrolled as well too. So in that case, right, again, is how do you differentiate the different payers and then what the requirements are so that you can get those claims out the door as soon as possible and then reduce your AR. For your Iowa, so for Iowa, this one does not require a claim. I'm sorry?
I think we skipped Nebraska.
Did we? Oh.
Go back one. There
Thank you. Thank you. All right. That's why we keep Dave around, so he can make sure I'm not skipping anything. So Nebraska also requires a claim. So again, being strategic about making sure that you have your border states enrolled is a really good way to do it, especially, or at least for the facility side, right? So who is the MPI and who are the states that you have the most? If you can get them enrolled ahead of time, that is going to be the best case scenario. The majority of the payers, once you submit an application, really can be anywhere between 30 days. There are some states like New York that can take up to 180 days to actually process the application. So just being aware of that, right, is again taking a look to see who are you enrolled with, who are you not enrolled with, and where is the majority of your inventory coming from. So Nebraska, from their perspective, again, they do need the board of directors' date of birth and social security number, and they need a claim specifically as well too. And then for, let's see, the next one that we have is Iowa. And Iowa also requires the physicians to be, all of your physicians that are listed on the claim to be enrolled. These guys do not require a claim, so you can start that proactive enrollment with Iowa and being able to complete that application. My recommendation is that if you have a person that's going to start these application processes, maybe have one day a week where they're actually taking that to your signer. They can get all those applications completed. Some of them are paper. There are some states like California in particular where you have to actually have everything gone through the portal for the signer to be able to sign the application. So again, it's just really truly understanding what the requirements are by state.
And just a quick place on Iowa. They do not have retroactive Medicaid. So if you have a self-pay patient from Iowa, make sure you're pursuing both of these, both the enrollment, provider enrollment and the patient's enrollment right away.
Did I see a question somewhere, Dave, or am I okay to move forward?
If we are, here's a question here is, if we are enrolled in Kansas Medicaid, are we required to accept all out-of-state Medicaid or just emergencies?
So that's definitely something that I would suggest that you go back to your organization, look at your compliance. What does your consent to treat form say, right? That really truly is something that is going to be a decision based on your organization, your mission, and what it is that you can do.
There's one question on OPR, just asking, do all states allow, would facilities still have to enroll from the OPR standpoint, or is it just for physician enrollment?
Yes, the facilities still have to be enrolled. So every state plan requires the facility 100%. And then depending on the state, then you have that OPR application, right? Depending on that. But the facility, every state requires some form of enrollment for an out-of-state payer.
And then we also have what is your suggestion for those facilities have local colleges in town that brings in athletes with out-of-state Medicaid?
So I'm assuming, right, that the types of services that they're getting, if it's through, like, for example, the ER process, those may or may not be covered depending on what types of services they're getting, rehab, those types of things. My recommendation would be is looking at that particular state and what are the things that they're doing to cover the particular services, because you also have some particular states that will only cover an account if it starts from an emergency. So Florida is one of them. The dates of services will be covered as long as it comes in through the emergency. Anything outside of that, they're not going to cover it. So it really truly is going to be depending on the types of services that they're getting and being able to see what they're actually qualified for. All right, Missouri, interestingly enough, the majority of the states, your border states, do require a claim. So there's not going to be a ton of enrollment, proactive enrollment in this case. So Missouri, again, is one that does require a physical claim in order for you to start the enrollment. So a copy of the claim would need to go with the actual application process. You do have, again, the board of directors information. It really, truly is. There's no way around it, right? The board of directors information in one way or another. And you'll see as we have different states, the requirements change a little bit different. My opinion is the states that require the most are going to be Texas, California, Florida, and New York. The rest of them really, truly, the majority of them, it's only going to be the date of birth and the social. But those other states that like Texas and California and those, they require the home address. They also require the driver's license number, not the copy of the driver's license, but they do at least they require the driver's license number. So again, each state is going to vary, but for sure, you're going to need that board of directors information to be able to complete that enrollment. All right, so we then have Arkansas. So Arkansas, this one, only thing that's going to be a little bit different outside of your social and date of birth is going to be is when is the effective date they became board of directors. So the application is going to require that information. And then again, you can see all of the different information that you need. Arkansas in particular does require also the physicians to be enrolled. So again, it's going to be dependent on that. One of the strategies that we're doing with some specialty doctors are that we are, for any of the states that we can do proactive, we're actually getting them enrolled, especially ahead of time, right? So with that OPR application, the OPR application typically will only last about a year. So that's something to be aware of. But being able to have your specialty doctors, right? Being able to, like the ones that are doing those really, really crazy surgeries that are going to be $1 million plus, making sure that they are enrolled for those particular states where you see some of those patients that are coming from. Some of them you may already know, right? You know that you have a partnership with maybe a border state. Those are the ones that are really important to ensure that there is already some sort of either enrollment or do you guys have a contract, whatever the case may be. But for those specialty doctors, my suggestion would be is then you proactively get them enrolled for the states that you have seen the majority of that traffic so that there's you're not waiting for that particular payer to complete the enrollment. That can really truly add anywhere from maybe 30, actually, I would say it could add an additional maybe 90 to 180 days to your AR for waiting for that enrollment process. I think typically what really truly takes the most time is gathering the information. The application process, my recommendation would be is to maybe have folks that maybe are really great at certain states. It's impossible to keep up with all of the requirements with all of those particular states, right? So how can you be more, proactive in being able to know which states require what? Having all of your documentation ready to go so that when there is a need to start that enrollment application, you have everything in place, you know exactly when that application needs to start, and then it goes off to the payer to be able to get that completed. All right, Oklahoma. Oklahoma also does not require a claim, right? But again, board of directors, the social, date of birth, those types of things. Nothing really truly different here. Oklahoma also requires the physicians to be enrolled. Okay, state of Texas. So Texas, one of my favorite places to visit, but it's also one of the difficult payers as well too when it comes to enrollment. So for enrollment, they will not allow any retro authorizations if you're not currently enrolled. So some payers, so the state plan in particular, so not necessarily HMOs, because you do have some HMOs that do not require any type of enrollment, which is really, really great. But for the state plan and for the HMOs that do require the enrollment that follow the guidelines from the state plan, they won't allow you retro authorization or retro enrollment. It's tough, right? So you've got to make sure that you complete that application as soon as you get that claim. And then once you have that claim and that enrollment application, you can start that process. The good news with Texas is that for the most part, the majority of the time, you're just going to require a letter once a year, just so that you can actually have your intent that you want to continue to be enrolled. It's not a full application process. But again, it is one that you need to be very careful about if it is truly that you have a large volume of patients from Texas. So the difference between Texas and the other states is, and we need the actual driver's license number, which state, and the expiration date for the actual driver's license. They don't need a copy of the driver's license. I will say, and I know that Kentucky is not one of the states that we have on here, but one of the difficult parts about Kentucky is that when you have your enrollment process for the physician side, so the application for the facility is a fairly easy process. You can be enrolled. I think the piece that's really becomes really difficult from Kentucky's standpoint is the physician needs to be enrolled. They require a copy of the Social Security card. So, and we have gone through, we've escalated, we've checked with our legal department just to validate, is this really truly a requirement that is required? We have gone through several meetings with Kentucky to see what we can do to get around it. Physicians do not want to have a copy of, they don't want to fill out the application, let alone give you a copy of their Social Security card or be able to have that application sent anywhere outside of their, how they feel comfortable. But truly, Kentucky does require a copy of the physician's Social Security in order for you to be able to complete the enrollment. So I do plenty of applications, we get approvals, but then I also have some particular facilities that may decide that they are just not going to enroll in Kentucky. And then they have different means of what to do with those particular accounts, whether it's, again, based on your organization, whether it's charity, or they move those accounts to self-pay. The other question, or the other key point that Dave mentioned earlier is that are these particular patients going to stay? Maybe they just moved, right? Are they eligible to maybe become in-state? And will they potentially have, depending on when that date of service is, could they potentially have in-state coverage based on that? I think that's the biggest key as well too, right? Is that, again, there's a difference between a traveler going to a different state or somebody that just moved that had Medicaid. And I think just partnering with your eligibility team from that perspective and seeing if there's any type of ways to get that particular patient to in-state. Do they have a Texas address? Those types of things, whatever the requirements are for your state, then I think that would probably be another way to review the information as well too. Get them enrolled in in-state and then avoid all of the out-of-state stuff for the future stuff, especially if, again, they are eligible and they qualify. So partnering with your eligibility team is really, truly key. New Mexico, I've mentioned New Mexico just recently revamped their entire portal. It took them over 60 days. So it really put a standstill on all of the current applications and you could not submit any applications. They did allow some leeway as far as retro, right? So for the most part, New Mexico allows you a year to be able to complete the enrollment. And for the, they do require the facility and they also require the physicians to be enrolled as well too. And then on this one, you can see, again, just social and date of birth, which is the majority of what I've mentioned for the board of directors information. All right, looks like we just have one more state. So the last one I have is Colorado. So Colorado, also social, date of birth. Colorado also requires both the facility and the physicians to be enrolled. The other thing that I didn't mention is on the physician side is there is two things that maybe could be very difficult is if you have physicians that are employed by your organization or if you have physicians that are just contracted, right? So how do you start that conversation with those particular physicians that maybe are just contracted and they don't actually are not employed by your organization? Having those understandings, right? And being able to see what you can do for those types of situations. Obviously, if they are employed, right, you have that type of partnership, communication, those types of things. But how can you partner with the group, especially for your ER doctors? The majority of ER doctors belong to a group. Some of them, they are employed by the facility, but again, just making sure that you have that information in place so that you're not getting all this information, you're not going through the enrollment process, and then you can't get the physician enrolled. So I think it's just making sure that it makes the most sense for your organization. That I have, and then we can definitely open up for any additional questions, is just again, what are your best practices, right? So from my perspective, the number one thing is that making sure that you understand what are the enrollment requirements for the states where you get the highest volume, right? In addition to that is, again, how are you validating and ensuring that that patient really truly is eligible for that particular plan? Because HMOs, right, there's a million of them out there. And so how do you get that information identified in order for you to be able to know what are really truly the requirements? You don't want to start an enrollment if the enrollment is not required for that particular HMO. So being able to look at that as well too, right? Partner closely with your physicians. How can you have a really good understanding and communication with your physicians? How are they going to be able to get those applications signed? How are you going to be able to have that conversation with the physicians? I have actually had conference calls with physicians where we walk through the application process. I explain to them the OPR process because, again, their biggest thing from them is obviously their information, right? Making sure that their information, personal information, is secure. And second, I think the biggest thing that they have is they don't want to be set up as an individual so that they are then now part of this particular plan. They don't want to do that as well either. So having that understanding with them too.
Guys, quick question.
Yeah.
Are there any state Medicaids that pay emergency claims without enrollment?
So not the state plans. There's HMOs within the states. So California, one of my favorite states, in two reasons. It's one of my favorite states because the majority of the plans from California, they don't require enrollment. There's only a handful of so the state plan unfortunately does require enrollment. And then there's a handful of payers that do require the enrollment as well. But the majority of them don't require any enrollment. So the great part about that is that you can actually just build a claim and be able to get that on there. California actually accepts paper. It's one of the very few states that still accepts paper. So you don't have to set it up electronically. But again, if it's a state that really you're going to get a lot of large volume, why not get that set up electronically so you know exactly what's going on with that claim? You can get the rejections, denials, updates, 835s set up, all of that good stuff. You want to be able to do that.
And then there's a follow-up question. Diane is having problems with Colorado Medicaid.
Yes, yes.
And customer service is not helping with denials. She wants to know if, yeah, with specific questions about different states, we'd be happy to talk to you.
Are you enrolled? Because you do need to have access to the portal. If you're not enrolled, that's the problem. Colorado in particular, sorry.
Required to allow retroactive enrollment back to the claim.
Colorado does, but Colorado, you do have to do everything through the portal. So whoever asked that question, that's probably what the issue is that if you're not enrolled and you're trying to get access to the claim status, if you're not doing it through the portal, that's the issue.
And there's a great comment from Pam that it would be great if all the Medicaids got together and processed claims similar to Blue Cross Blue Shield. Yes.
Oh, man.
That would be amazing.
That's right. It would make my job super easy, right? And if the other thing would be great is that if they just did it so that you have your enrollment done once and that's it, right? Once you have really truly gone through the process, you have proved that you really truly are an organization, the services have been rendered, why having to do it every year or whatever the case may be. I know.
And then here's
Our
one
world would be easier.
final question for this little interlude. Typically, you must be enrolled with the state Medicaid plan to enroll in the contract with the Medicaid managed care plans.
Yes.
Yes. And then
Yes.
in your experience, do these plans recognize retroactive enrollment for the date of service in question?
Yes. So the majority of the payers out there, that is the good news, right? So although there is quite a bit of hoops that you have to jump through, you have some time to be able to jump through those hoops. The one, like I would say, is Illinois. Be very, very careful with Illinois, because Illinois is fast and furious. So you have 45 days, and not again from the admin date, not from the discharge date, it's from the admin date. The majority of the payers do allow you to start that enrollment application, and you can retro up to a year from the discharge date. But again, you don't want to wait too long, because it could take them anywhere between 30 days to 180 days. Or you may have situations like New Mexico, where now they're wanting to update their portal and you don't have a way to be able to start that enrollment process. So they are going to allow us to still do New Mexico, even though they were down for that period of time. But my AR, right, for that particular state is increased, because we're not able to get through those applications until they complete their process. So Texas does have some payers that will not require any type of enrollment. That's where I'm saying that it's key, right? Because you want to make sure that you're keeping up with both what are the requirements and then also the deadlines for that particular state. So just to sum it all up, right? Stay up to date with the changes. What are some of the things? So for example, as I mentioned, New York there's been talks. They kind of go back and forth about maybe potentially requiring the physicians to be enrolled. Today, they don't require that. And so those are some of the things that, as they're bringing the information up to light, I'm thinking, okay, how many New York claims do I have outstanding? And what do we need to do to ensure that the folks that are not enrolled, let's get them enrolled for the facility side. And let's get that done as soon as possible, so that then we don't have to then jump through another hurdle on the physician side. The biggest key thing is to success here is, again, understanding the specific states, right? And what the requirements are by payer. It may be impossible to look at every single state, but at least focus on your border states, or maybe even on your high dollar accounts, right? Again, who is it that's really truly taking care of those patients, and maybe taking a look to see in the last 60 days, 90 days, even a year, where are those patients coming from? I think you may be surprised how far some patients travel. Again, and it's going to be depending on certain timeframes. I've noticed that we get an increase during the summer. We get an increase during the holiday times, right? Because again, there was a little bit of traveling. So in that case, that happens that way. So the other thing too is that just, again, making sure that your HACOS forms, so the way that you have things registered through Medicare. And there's an inside joke in my department. Is it PACOS or PICOS? I guess it depends on where you're from. I'm from the state of Utah, so I like to say PACOS. So it's PACOS. That particular process of who all of your board of directors that you have listed, really truly keep that up to date. Because again, if it's not up to date, you submit an application and it's a state that is going to validate that information to the T, it really then delays the whole process for a long time. And then now you're going to be required to potentially do fingerprinting and background check for board of directors. And as you can imagine, that's a really difficult task to have to do. The other last thing that I have is, I think it's maybe important to take a look at your enrollment thresholds, right? So maybe you don't tackle everything all at once. Maybe you start looking at your accounts that are maybe based on your organization, right? Maybe over 100,000 or maybe over 50,000. And then you can then start looking at other particular thresholds, so that you don't feel so overwhelmed and try to do everything at once. Or if your organization has never done the enrollment process, right? Maybe start with that $1 million claim, right? What state is it? And maybe start that process that way. Key piece would be is to work with whoever's doing your Medicare enrollments. They have practically everything that's going to be required in order for you to be able to complete those applications. All right.
And there's a question here is, do you have some sort of cheat sheet that lists the states and the MCOs, and if they require enrollment and the requirement enrollment in the process?
So we do have the cheat sheet that's going to be part of the presentation for the physician side. And we do have that. And then, like I said, from the state plan's perspective, every one of them is going to require some form of enrollment. As far as the HMOs go, like by the specific, there's literally hundreds of them. And so from our internal process is we have everything within our host system so that we can have the specialists look at the information. They don't have to look at a spreadsheet. They don't have to look at anything. We are keeping everything up to date within our host system. So we don't have an actual, like, I don't have a spreadsheet per se. Everything is in our system so that, again, there's no question, there's no confusion. We can run reports. This account has been billed, but it's not enrolled. What's going on? So for me, I don't have anything specific that I can send out because everything is in our system, but I can tell you that every state plan requires enrollment, and then we'll send out the physician portion of it as well.
And putting together a cheat sheet, it would only last about a month, and then it would be.
Yeah, I mean, I think that's the difficult part too, right? Is that you have new payers coming on, you have requirements. I will say that from an enrollment perspective, they are pretty good about letting you know ahead of time. Louisiana, and I know that wasn't one of them, but Louisiana, man, I want to say it was last year or the year before. Sorry, all this enrollment stuff sometimes gets all squished together. But last year or the year before, they sent out an update letting everyone know that they are wanting everybody to confirm that they really truly still want to be enrolled with Louisiana. And if you were enrolled with Louisiana before, you didn't have all of the requirements that you had. It was just something that would just continue. You would essentially be enrolled with Louisiana forever. They did give us a heads up on that. They gave us about a 6 months heads up that they were going to now require everybody to just submit a form that says, yes, I still want to be enrolled with Louisiana. It required a little bit of information, but definitely not the full enrollment. And for those folks that didn't take advantage of that, now they have to go through the full process and complete the enrollment in particular. So from the beginning to the end.
I would recommend just keeping track of your surrounding states, because primarily are your biggest volume states. If onesie twosies from Maine or Florida or Georgia, you can look at them and see if they are financially viable to go through the process. Thank you. Is there any other questions? It looks like we have a few minutes left. You will get it. Everybody will get a copy of this presentation. You can see my information right there. If you have any follow-up questions, if you have anything that you want us to talk about in more detail, happy to take those calls or emails. Just let me know.
All right, David and team, I don't see any more questions in chat, but I would just give a moment. I give some closing comments, which is just thank you. This was so helpful and just a ton of information. We will be sending out the slides afterwards and the resources that Jez mentioned. But with that, I just say have a wonderful afternoon, everyone, and a good day. Happy holidays.
Thank
Take
you
care.
so much.
Thank you.
Bye-bye.
Bye.